All right, so I know I said that we have a special guest, and today's special guest is Major Britt Geisler. Let me go ahead and get her on here. Ma'am, can you hear me?
Yes, I can. Can you hear me?
I can.
Perfect.
So we reached out to Major Geisler. So why don't you go ahead and explain, first off, your position?
That's always the hard one to explain. So I'm the Medical Recruiting Brigade's Recruiting Integration Officer. So I am the special staff advisor at the Recruiting Brigade on everything medical corps and kind of the physician advisor. I also interact with the medical corps and kind of advise them on recruiting. So I'm kind of the liaison between those two entities in our organization.
So she's one of the people that, say you come talk to me and you're a doctor. I can tell you everything about the programs. And then you're like, what is it like in this situation? It's like, I don't know. Like, I'm not a doctor. I really, really can't talk about it, but I know someone who can. So this is the person that I would actually refer you to. And she is the absolute subject matter expert when it comes to Army medicine. No pressure there.
The absolute, if there's questions I don't know the answer to, I can find them out or connect you with the person who does.
But she kind of guides our, kind of who we're looking for and the way that we look for some of these professionals. Why don't you go ahead and give us a little bit about your background? I know you're a doctor.
Yes.
And how did you end up on a special staff at Recruiting Command? I know that's a very long and loaded question.
But... Yeah, the long and winding road. Well, I was writing down my path actually today.
Well, let's start off with this. What was your commissioning pathway? Did you take HPSP? Did you take strap? Or were you direct commission?
ROTC.
Okay.
Yeah. 20 years ago this year in October, I signed my first Army contract.
Congratulations.
Yeah. And looking back at the past 20 years, I went through ROTC and then I went to Uniform Services University.
Okay.
And then did my OBGYN residency at Brooke Army Medical Center, and then had a few assignments as a OBGYN. One was at Fort Polk, Louisiana for 3 years. And then while I was there, I got the Fort Polk vacation to Afghanistan for 9 months. And then after that, I went up to Alaska where I got to practice really good medicine in a very remote place. And after that, I was looking for broadening experiences and to give back and help the Army like they've helped me, and got the MRB position, which has been so amazing. I've been here for about a year. So everyone says when you go to Fort Polk to Alaska, who did you make mad? Because those aren't the most glamorous duty stations, but I always say the Army gives you what you need, not always what you want, and that's exactly what I needed in my career.
So funny thing you mentioned that, because I don't know if you were watching a little bit earlier. We actually had Colonel Ballou left us a comment on here and said that the Army allows medical professionals to bloom where they're planted. So it may not be your top spot. And ma'am, I'm going to have to talk to you about that one. Are you trying to say that you didn't want to be here with us?
No.
I'm getting that.
The path that I would have never got onto the path to be here and be influenced the future of my own corps if I would have never taken those hard assignments. And this is a hard assignment too. It's challenging because, I got thanked for my service in the Medical Recruiting Brigade by a bunch of Medical Corps 06s. They understand that recruiting is so essential, but so difficult because even though it's such an amazing job in life, it is a difficult sell, especially for fully trained physicians out there. So they know we're fighting the good fight. And so Yeah, yeah, and but Colonel Blue was exactly right. You bloom where you're planted, and I would not be the physician and officer I am today without those challenging and growing experiences like Pork Polk.
So I know you mentioned U-shoes, and we actually haven't mentioned that at all today, or even yesterday. So that is an additional pathway now to becoming an Army medical officer, actually just a military medical officer. So it's the Uniform Health Services University. I think I got that right.
Uniform Services University. They go by USU now. They used to be Uniform Services University of the Health Sciences.
Yeah.
So it used to be USHIS.
Yeah, acronyms.
So Army. But now they go by Uniform Services University because they aren't just a medical school. They also have advanced graduate nursing programs. They have advanced medical sciences programs, like PhD programs and those kinds of things. So they're not just a medical school. And they go by the moniker of America's Medical School. So that is sort of our competition in the recruiting, but we go hand in hand. It's one team, one fight, really.
Yeah, and it is extremely competitive to get into. I think the last time I looked at the number of slots, it was in the double digits. So it is not much per year. And with that, so a lot of people apply to U-shoes, and then they're directed right back at us for HPSP or for some of these other programs. So if you are interested in U-shoes, by all means, go check it out. But if you need as far as like dual applications and stuff like that, please reach out to us on that piece. One of the things, I know you mentioned that you're an OBGYN. In the Army, I don't think we're looking for it next year. I believe that actually got taken off. But it is one of those things that they do exist in the Army. And
they do.
Yeah, and she is proof of it right here. I've worked with OBs. Actually, what's funny is I met up with an OB downrange who was serving as a profist doctor because they had thoracic surgeon specialty. Period. Like that, they had that. They were cross-trained in it. They had that skill set, so they were utilized in that field. Some of the other specialties that I've run into, like I said before, pediatric oncology, hematology.
I was deployed with a pediatrician and an ER doctor, and I deployed as a general medical officer. So I was a battalion surgeon. Yeah. So I was taking care of anything that walked into my aid station. And I was lucky to be co-located with a forward surgical team. So they were really excited to have another set of surgical hands on deck. So I got involved in their surgeries, and the orthopedic hand surgeon taught me how to sew on fingertips because soldiers like to pop off fingertips.
We do some not smart things sometimes.
45-pound plates, and so he watched me do one, and then the other 3 after that, I was on my own, and he was there if I needed him. But yeah, a lot of cross training and a lot of really interesting things. And yes, there are pediatricians, there are OBGYNs doing full scope. And
so that's one thing that because I know this was put out on the military HPSP students page on Facebook. Mm-hmm. And I see a lot of talk going back and forth. It's like, what specialties does the Army have? And there's a lot of misinformation that I want to say that's on there. So they're like, you're going to be emergency medicine or you're going to be surgery. It's like, why do we have a urology residency? Why do we have if we have a residency, why are you saying you're only going to be emergency? And I kind of want to let you go ahead and take this one a little bit. So I know we have these specialties. Mm-hmm. For those who are interested coming from HPSP, whether they qualify directly out or not, is the possibilities going to that. And the other thing I wanted to ask you about, friends of mine that I've worked with, former flight surgeons, so I think you know where this is going. They have taken flight surgeon rotations while they're waiting for other residencies to open up. For example, dermatology and ENT. I know 2 flight surgeons that I both worked with. One's an ENT that I'm trying to get him on the show, and the other one's a dermatologist who recently retired out to the middle of nowhere in Colorado and doesn't even have a cell phone signal at his house. So as soon as he gets an internet connection, we're going to have him on here. But I kind of wanted to touch base with you, kind of explain what the process would be. Not only they're going through the match and the subspecialties that are available, but also what if they wanted to wait? So I'll go ahead and let you kind of take that.
Yeah, I had a undergrad ask me how I became an OBGYN in the Army. And I said, well, I wanted to do it. There was a slot. I applied for the slot. I got it. Like it's because of the way our GME, the graduate medical education or residency training programs, we're the largest, Army is the largest one in the Department of Defense. So we have more options. So the way that's set up is that we are training for all missions, such as our combat mission, as well as care for those at home. So we need to have the family practice, the family medicine doctors, we need the ER doctors, we need the general surgeons, but we also need the other areas of expertise to go along with those programs. So it all kind of intermingles and intertwines and supports each other. Family medicine physicians need to learn from pediatricians, need to learn from OBGYNs, because that is part of requirements from the ACGME. So every single residency program in the United States Army is accredited nationally by a civilian organization where they tell you what you need to learn. So it's not like you're getting a different education in the Army. You're getting the exact same one you'd be getting in a civilian hospital. So we have check marks that we have to do, and you need certain times. Like I did a SICU rotation, so a surgical ICU rotation in my OBGYN residency, because that's what I needed to do in its intensive care. So we have urology, we have radiology, we have, flight surgeon, aerospace medicine, general surgery, orthopedic surgery, ENT, ophthalmology. One of the readiness things is LASIK and PRK for our soldiers. So these ophthalmologists they have centers of excellence where they're just rocking PRK and LASIK because it's a readiness issue, getting our soldiers not to require glasses so that they are more adept and able on the battlefield and just in every day. So we have multiple missions that are outside of just the combat. Everyone thinks of combat, they need the ER, you need the trauma, but there's other things. And I think especially what brought to light with COVID is, we need our internal medicine, we need our intensivists, our cardiologists, because the Army mission isn't just downrange. The Army mission is at home too. So if you want it and you have the passion and there's a slot, you apply for it. If you want to wait, you have to do at least 1 year of what's called an internship or PGY1 or FIGME. There's lots of different terminologies for it. First year graduate medical education. And we have tons of transitional year programs in the Army. So you do a transitional year and you can go out and be a general medical officer where you take care of soldiers. And some people do that to be more competitive on those uber competitive residencies. One of my buddies did that, and he did his general surgery internship and then went out and did a utilization tour, and he got neurosurgery. We have that too. His rotations can make you more competitive because you have that Army slice of life too. So there are programs that require you to do a transitional year, like aerospace medicine, dermatology, those ones that are a little bit more competitive.
Let me hit on aerospace really quick. So we actually just talked about, I don't know if you were watching the research presentation, but when we hit USARIL, I come from an aviation background. I spent time in aviation, and some of the flight surgeons that I've worked with, absolutely amazing people. Captain Gomez, if anybody has ever heard of Captain Gomez's story, his helmet is still in his office from taking an RPG round to the helmet. And there's pictures of it
all
posted.
those research labs, because
Exactly.
they do when you do the mishap investigation, they take everything. I got to go to flight surgeon school when I was at USIS, so back in 2009. So
I went to, so the cool thing for me being the aeromedical NCO, we actually get to go through the flight surgeon course. We learn what you guys learn, to learn how to run your clinics efficiently and effectively. But the USARIL lab is just amazing, and the partnerships that they have with NASA. When you go into aerospace medicine, through the RAM program, and there are several people I've talked to. Colonel Salmon down at Fort Rucker.
He was my instructor in the course.
So people like that.
It's back then.
Yeah. So people like that, and there are so many things, and it's not just in the Army. Like I don't remember if it was him, but I know one of the other ones that I worked with, and I know he wouldn't want his name published, but he was working with the aeromedical research with NASA, researching the effects of outbound and reentry G-force on the body, on astronauts. Like that was his focus when he was working for NASA, and he did it for several years. And it also comes down to like aircraft mishaps investigation. So it really does look at the whole scope of an Army doctor. No, you're not just sitting in a clinic treating patients.
If you want to, you can. If you want to be a clinician, you could be a clinician, and we need excellent clinician leaders. But there are different tracks that you can take, and be leaders and researchers and do really, really crazy cool things.
So we just got a comment. So if you don't know, all these comments I can see are coming in live. So actually it's for Sergeant Wainick. Question for you. Can you explain how deployments work for Army physicians, and how often can they be expected to deploy? Now, let's kind of break this up into two separate sections. I know you said you deployed for 9 months as an OBGYN. So that is active duty. Let's take the active side first, both organically assigned and profis. And if you don't know what that means, we can kind of go into it and break it down. And then let's hit on the reserve side. So the reserve side, it's much, much different because you have your own practice to manage as well. So ma'am, go ahead and take it away. So let's say, go ahead and
the organically assigned physician, that physician is owned by that unit. You are their doctor. So you're their brigade surgeon, their battalion surgeon. You live and breathe what the unit does. So you will go that whenever that unit goes on their battlefield rotations, you will go with them the entire time. Profis it's a professional filler system that's changed a little bit, but it still gets where they take a physician from the hospital and attach them to that unit, and they go only during certain parts of that unit's mobilization. Sometimes the physician can split up their deployments. I went for 9 months because I volunteered to. That I didn't want to split up my deployment, and the other physician that was there was actually two physicians that split their deployments in half, so it was a rotator, and that can happen, not guaranteed, but can happen. But I went for 9 months because I volunteered to, and I really, really, really enjoyed my time in my unit, and it was such an amazing experience. It was such a cool experience, but.
So that's the active duty side.
Yes.
When you were there, so I know it really does depend on the type of unit and what you're going to be expected to see downrange. We've had people everything from a battalion level aid station to like Bagram Hospital and everything in between. So it's really difficult to say this is what your deployment's going to be like. I mean, you can talk on your experience. I can talk about what I've seen when I've deployed. So I won't quite touch on that. That's more of like when you have a one-on-one conversation with your recruiter and they say, hey, let's put you in contact with Ria. Well, you're going to probably talk to her. But they can also put you in contact with former medics, with medics that are currently on assignment to USREC, and even some of our physician recruiters and our OICs, they have experience with that too. So let's switch over to the Army Reserve side.
The Army Reserve side, right now they have a policy of 90 days boot on ground. So that is, or 90-day BOG. So that the goal is for the physicians to only have 90 days at that mobilization site, wherever it is, at whether it's in the United States, backfilling in Kuwait, or going to Iraq or Afghanistan. They try to do 2 years stabilization in between the deployments. The active duty side, how often you deploy really depends on your job, what type of physician you are, and the rotations and how frequently that job is required, kind of. So,
and so like you said, with it, typically that 2-year stabilization. Now, when you say deployment, again, it's not always to a combat zone. Yeah. Like I mentioned before, I've had she was an ER doc. Now it's Mrs. Bowder, so no longer Colonel Bowder. She came on board and she's like, I want to deploy. It's like, okay, cool. 90 days in Germany. That was her deployment, was 90 days in Germany, because we had a doctor go on leave and then was PCSing, but we didn't have anybody inbound, but we still had an entire empanelment to fill. So there was an empanelment in Germany, so they can't get care on the civilian side. We can't refer them out. So we needed to bring in one of those doctors, and she fit the bill for that. Mm-hmm. I've seen it in Hawaii quite a bit. You see it a lot with OCONUS, because there's only a certain number of active duty that can be at that location. Can I talk on this mystical website that we've heard, where you can volunteer for the deployments?
Mm-hmm. That is the mystical. Is that the one that on S1Net it talks about all the wise taskers and the ones? But I know my Colonel Reed she's now retired Dr. Reed. Yep, it's July. People are retired. He was the USARC surgeon, and there is you can discuss through your chain of command. You can go and you can actually control your mobilizations a little bit. Yes. And I always recommend I volunteered for deployment, so I got a little bit of control over my life. So volunteering for MOBs, definitely you can have a little bit more control than it needs to be filled last minute. So you can kind of do the backfills in the cool places and those kinds of things. So it is possible to do that, to kind of control your environment and what happens to you. And you can ask them nicely.
So little off topic. Are you at home, or are you working from home, or are you in the office?
I'm working from home because I don't have Google Chrome on my Gov computer, and this needed Google Chrome.
Yeah.
So,
and what is behind you?
This is my husband's workshop. Okay. And I was like, well, I can't have a background of books because everyone's gonna, zoom in and figure out what books I have. And then upstairs is just exploded from a 3-year-old. So he's out on a nap. That's why he's not bothering me for a snack. So we're just like, where can we go? And this is my husband's workshop. He's a saddle maker and leather worker. So I figured, I was like, yeah, he has the American flag.
No, that's actually really cool. So it's one of those things, you don't see a setup like that every day. And it shows that contrary to what a lot of TV shows and stuff say, we don't live in barrack style open bays for our entire life. We don't. We have houses, we have hobbies. I'm a home brewer. When I retire here in about 7 years, I'm going to open a brewery. That's my goal. And it is interesting to show everybody's kind of their human side to it as well. So
I went to Oregon State for my undergrad, and they have masters in all kinds of brewing stuff. They have actual academic programs. Look at that. I'm all trying to recruit everyone all the time.
I've looked at it. But like I've made my decision. So I want to go into the business side. So I'm working on my MBA right now. I can brew, that's fine, but I don't want to be that brewer for the rest of my life. I want to own it. I want to manage it. So that's where it's the little bit different. That's a little bit about like my future plans.
Yeah. I was a micro major, so I was like, I can actually be a brewer when I grow up. And so I was like, if I get out of the Army, and I'll go get my master's in brewing or something. But
so I know you said you went OB. You said Fort Polk, right? I know we've mentioned Fort Polk here quite a few times because we discussed one of our phase 2 IPAPs that we've had contact with.
I've worked with them.
She picked Fort Polk because there's nothing around Fort Polk and she wanted to make sure she studied. And then you mentioned some little podunk place. I'm guessing Wainwright.
Yep. Fairbanks, Alaska.
Yep. That is a very interesting place. So pretty much when you fly into it, it's like snow, city, land.
Yep.
And so when we say like the people who come in as doctors in the Army, doctors, nurses, any medical professional outside of like the service corps and the research side, because we just went over that, you literally can go any place where it says Fort blank.
Yeah, and I said I've had a small medac life. So medac is the medical activity, and those are small rural-based hospitals. Fort Polk was smaller than Fort Wainwright, Alaska. You'd be surprised. And I've had very rural general OB experience, and like I said, like Colonel Blue said, you flower where they plant you. And I went from a huge hospital where our medical centers, where there's everything under the sun, a level 1 trauma center at BAMC, to a very small place with very limited ancillary services. So I was not forced, but I was able to figure out how to stand on my own 2 feet as a physician and as an officer. And I was able to continue that and grow organically, where if I probably, in some ways, it all prepared me for like when I was in Afghanistan and I was like, you don't have this. I'm like, oh, I'm totally used to that. It's not big deal. And it made me the physician that I am today. And people, you can stay at the larger medical centers your entire career if that is how your track goes as well. If you specialize, like for GYN, we have maternal fetal medicine subspecialist, urogynecologist, minimally invasive gynecologist. We also have gynecology oncology, and reproductive endocrinology and infertility. And those are all subspecialists within the OBGYN community that the Army actually has fellowships in. Sometimes they have more fellowship slots each year than they, but once you become a subspecialist, you stay at the larger medical centers. And those are, the big ones. Walter Reed, BAMC.
Speaking of fellowships, I know you said like the Army does have positions for these extremely specialized fields. So for you as an OB, if you wanted to go into this fellowship, now we did discuss LTHET as far as for the nursing side. What would be the procedure? Is it an application? It's the
match. It's the same. It's through mods. You go through and you apply for a fellowship through the mods match, and it's the joint. It's like 7 letters long, like the Joint Services something selection board, GME selection board.
Some other acronym we have.
It's a huge acronym. I'm sorry, Colonel Maurer, I don't remember the acronym. He's the deputy director of the Army GME, but you join the match, but it's match for fellowships, hematology, oncology, interventional cardiology, ultrasound for ER doctors. And they're all training that you get while you're still in the Army, to specialize. They have those programs.
This is awesome, because that is one of the questions. Now, typically I get the questions from like med students, and they're like, well, what about fellowships? It's like, do you know what the match process is like? I'm like, no. Like, okay, let's talk this first, and then go through the process. And it's like, no, there are absolutely fellowships. Like, well, I heard there wasn't. Like, yes, there is.
There is.
Now, when you're watching this, she said it. It's there. She is the recruiting integration officer, so you can't blame me.
Yeah, and another thing that people don't realize, well, when you're in the Army active duty medical corps, is there are frequently, not a lot, but you can actually change your career path and go to a second residency. And I have a buddy that was a pediatrician, and then now a dermatologist. But was a pediatrician, then went back to residency, and now he's a dermatologist. And one of my mentors was an OBGYN and went back to radiology residency. Now he's a radiologist. So you can, and you're active duty, and you get paid active duty pay, and you train, and you get another feather in your cap.
So you're currently at Fort Knox now, correct?
Mm-hmm.
Yeah.
Yes.
I ran when I was stationed there before I came over here, I actually ran the SRP site, the Central Exams Clinic, the Aviation Clinic, all at Ireland Hospital before the downscope. So we downscope to pretty much from a hospital to a clinic. Now, because you're a physician and you're working in one of these broadening assignments, do you still have to do clinic hours? Do you still how does that work?
Yes. Yeah. Well, I'm credentialed at the clinic. So they're able to use me anytime they need, because they still have women's health nurse practitioners. They just don't do obstetrics there. So I'm still able to see gynecology clinic. And then within the Army community, I have friends of mine who's like, hey, can you come work with us down there? So, I mean,
Fort Campbell for a little bit.
I can go down to Campbell. I can go down and work at Fort Hood for a little bit, at Fort Benning. I just need to get through the credentialing process and do the time. And it's really my commander, Colonel Mandrill, was like, yeah, whatever you need, as long as I'm doing my job here, I can have the clinic time as well. I know that some of the physicians that are at HRC, our Human Resources Command, have a schedule where they go every week and work at Ireland. Before COVID, I was traveling a whole bunch, so I wasn't able to have a regular schedule to do as much clinical as some do.
Yeah. So for those people that don't understand, Fort Knox is kind of the hub for everything accessions related. So when I spoke before about accessions, that's your onboarding type situation. Sorry, I'm getting texts with questions.
I know. It's like I probably should put my Gov phone on quiet and stop it from vibrating.
But Fort Knox, so it's the home of Recruiting Command. It's the home of the Medical Recruiting Brigade, which we both fall under. Mm-hmm. It's the home of Cadet Command, which manages all your ROTC. So any officer pipeline, it gets routed through Fort Knox. Like that, guaranteed it's going through there. To include HRC, so Human Resources Command, and that's where all of our career managers. So my career manager is located up there. Yours is, and there's going to be one of your peers. So a doctor in the medical corps managing medical corps careers. Mm-hmm. And the cool thing, like you mentioned it, is we do reach out to them when I was working there all the time for readiness processing. If we needed backfill. So if we had a doctor that wanted to go on leave, we'd reach out to HRC, be like, hey, can we get like one doctor per week to go ahead and see people? And like I said before, if we found out there was a RAM or a flight surgeon in there, we're like sitting there like beating on the door because they won't let us in, and we're like, hey, we need you, come here. So it's definitely great, at least that you're able to maintain your clinical proficiencies, even though you're taking these other positions as well, command positions and special staff and whatnot. So it's good to hear that we're not letting like doctor skills like kind of go by the wayside, because everything is perishable. It truly is. And
they're doing really, really cool things, because the medical corps is started to do surveys of their physicians to ask them questions, and the medical corps leadership is listening. So there are MilCiv partnerships in place where we have military physicians and teams embedded in civilian hospitals for skills sustainment and trauma places. And it's, we have some at OHSU in Oregon and, scattered around the country, and we're building those relationships so that those general surgeons that might be in a low volume place, can go to those higher volume places to maintain their skills. I used to tell people I am a low volume OBGYN. I've been, but very high volume OB, because at Fort Polk and in Alaska, people are known to have their expand their families while they're in the small remote places. And I never worried about that because I did have the OB to keep the volume of my surgical skills up if I wasn't doing a lot of large GYN surgeries. So it was always a kind of a balance. But there's some studies coming out from the ACOG that are saying that volume is important, but it really is the status of your team that morbidity and mortality decreases if you have the same team. And at small places like that, like I mean, did I dislike Fort Polk greatly? No, but what I loved was my team. I loved my team, and at Alaska, loved my team. I mean, the people who were there at my son's birth, I was there for their kid's birth. Like, they knew my kid. Like, everyone knew everyone. So we worked in such a tight knit group that our people were shocked that my complication numbers were low. It's against what everyone says, higher volume's better, but I'm like, my complications numbers are perfect, and I don't have thousands, I have hundreds. So,
and you kind of hit it on the head with that one. So I've been quite a few different places. I've been to Germany, Hawaii, Fort Riley.
Completely opposite. You got all the good ones.
Well, I said Fort Riley. Come on. I've been to Fort Knox. But here's the thing. I've been some excellent locations and have been miserable just due to, like you said, it's the team. So you may get assigned to like this awesome place. Well, guess what? If you're assigned to this awesome place and you're out doing stuff day after day after day and you're not home, it's not fun. And that's why I tell people a lot. It's like, don't discount the smaller places. Like, when people hear it's like, oh, I'm at Fort Knox, and like, oh, like, I love Fort Knox. I truly did. Like, I had a house down in E-Town. When there wasn't that craziness outside of a normal military installation, it's not that you really had to worry about. And the population of Fort Knox is generally more senior, not senior in age, senior in rank and stuff like that. So you don't have, I'm sorry, Fort Riley, but the general stupidity that you have with BCTs. So it really does make a difference in your career about not necessarily the place, but do what you want to do. And that's going to make or break your experience. One thing I did want to kind of hit on while I had you on here, a question that was asked, he's an infectious disease internal medicine doctor, and he is a sole practitioner, and he has his own staff. He has his own everything. And coming into the Army Reserve, his major pretty much sticking point was with him leaving for any length of time, whether it's 90 days or not, that's going to put his nursing staff out of work. And say, what would you say to somebody like that?
Should have prepped me with these questions. No, just no. I've never practiced civilian medicine. I've never been a business owner. So that is really, I know there are options for locums, but it depends on what his business model is, and how much he wants to serve. And I know the UAMTFs were the task forces that were deployed for COVID were using all of our internal medicine and infectious disease doctors. So, I mean, those are ways that they could be used. And when, especially in a situation like that, where there is no elective things going on, to serve in that capacity is definitely a really cool opportunity.
So I know that was kind of a tough question and kind of a curveball for you, but
that's fine.
It's some of the questions that we get asked around here, and from that's why I just kind of wanted to get a physician's perspective on it. And
it's a hard question, because then you're responsible for other people's livelihoods, and what to do when you're a business owner. You're responsible for people's livelihoods on top of being a physician. And those are questions that they have to talk to their family, talk to their staff, figure out what works best for them. Military service is awesome, but sometimes it's not right for everybody. Also, sometimes it's not the right time for everybody. And service is so there, with service, there's sacrifice, and not always when it comes to money, but for us, it's moving every 3 years, but that service and sacrifice comes with other things, like having a family of friends scattered all throughout the world, that we can call on. So stuff like that. And that's, we can't, as recruiters, we can't answer that for them. We can just say, well, I hear you. I hear you. Yes, that is a very difficult decision to make.
Don't feel, felt, found me. No, but that's, I mean, good answer. There is no correct answer to it. That's why I just wanted to pose it. But I do want to, I want to thank you. I know you said you had a little one sleeping, so I'll let you get going, and thank you.
Like 2 hours, unless you have somebody else, or do you need a break? You've been going at this for 4.5 hours.
And I got another day tomorrow too. So, we are going to take a quick break, because after this, we're going to follow up on dental core and kind of talk about undergrad nursing for a little bit. If anybody has any questions for Major Geisler, you can go ahead and leave them in the comments. I can easily go ahead and email them out to her, at least get an answer on that one. And if you have any questions as far as becoming a doctor, whether it's through, like you said, UShoes, whether it's through or UHS now, maybe USU. So we don't recruit for it, so I don't really pay attention to it. But even going on to like HPSP through the STRAT program, and kind of getting the physician's perspective and what they think of it, like I'd be more than happy to go ahead and put you in contact. So
and I tell people, even though I didn't do HPSP, really the HPSP is the road to Army graduate medical education. So the residency piece, which I did do. So I might not be able to specifically talk to you about how life was in the HPSP. I can talk to you about how life was in Army residency, because HPSP you're required to go to Army residency. So that's usually where I go to when I talk to the people who are interested in HPSP, because really once you get into medical school, then the world hits you and you're like, now what am I going to do next? Now how am I going to be the specialty I want?
Because here's the thing, medical school really doesn't matter. Yes, it matters because it gets you to the next point, but
it gets you to the next point.
A med school is a med school is a med school. As long as it's accredited in the US, they're roughly all the same. They all need to check the same blocks. where you're really going to make your bang for your buck is that residency. And that's going to drive your career.
Mhm.
And so that's the piece that you really do need to look at.
Yep.
All right. So it doesn't look like there's any other questions. Thank you so much for coming on, ma'am. More than happy to have you on.
Thanks for doing this.
Yeah. And it's the same thing. Congratulations on 20 years. I don't know how much longer you're going to be, staying.
Oh, that's just that was my original. That's when I signed my life away.
Oh, okay.
It's still, that's when I signed my life away. Then I commissioned in 2004. It's been a minute, but
yeah. All right, cool. Well, I'll let you get going again. Thank you so much. And I'm sure we'll be in contact later. I might even try and get you on the podcast as well.
Heck yeah. All right. Talk to you later.
Bye. All right. Bye. All right. Hey, thanks everyone. Thank you for that question. I hope that kind of answered some of the questions that a lot of people have had. I've sat down with many med students, many residents, and even just people who are in their undergrad that it's like, so their initial site is on entry to med school. So it's like, guess what? That's like the 5-yard line. Now what? Like you need to keep going the rest of the way. And at least kind of this will give you an insight into the Army residency programs, the program itself and how it works, and especially the fellowships and going into the subspecialties as well. Cause it's a big question that a lot of people have. And if you do have any questions, like I said, leave us a comment. You can go ahead and text me. And if this is something you want to pursue, if you either follow the link tree, goarmy.com/hiring days, or text AMMZ, we can go ahead and get you in contact with an AMED recruiter actually in your area. So that way it's you're dealing with somebody face-to-face. You're not trying to do something remote, and we'll get you in contact with somebody local. But for right now, what I'm going to do is go ahead and take about a 10-minute break. Up next, we have Sergeant First Class Fitzwater, and we're going to go ahead and talk about dental core. So this is anything from, well, I know we discussed dental HPSP, but any of the dental specialties. And one of the ones that you don't really see too much on the civilian side is called the comprehensive dentist. And we actually have quite a few of them to include a residency for it. So stick around. Go ahead and jump over to YouTube, over to Facebook, like our page, set a reminder so that way the next time we go live or anytime we post a video that you're reminded of it. The other thing to take a look at is right up here, Careers in Army Medicine. So that is my podcast. It is not necessarily just the recruiting side of it. I want to try and get at more of the human side where people are coming on, telling their story, telling why they did what they did, and also the pathway that they took. So head on over. It's on iTunes. It's on Stitcher, Spotify, wherever you listen to podcasts. Go ahead and take a look at it, like, subscribe, and leave us a comment. All right, cool. I'll be back in about 15 minutes or so and with Sergeant Fitzwater.